Good day. We'd like to welcome you to our Health Information Technology Safety Community of Practice webinar, which is a result of many polls that we have done of our audience that wanted to have access to this either live or in the near future to come back to. I'm Charles Denham, Chairman of TMIT, and I'll be covering some of the housekeeping details and then a few things in the news. First off, please turn your volume up on your computer so that you can hear get the best audio. And if you have a problem, and we're on slide 4, you can click on the telephone icon in the lower left-hand corner of your phone or your screen, and that will give you access to a direct line. If you go to safetyleaders.org, which is our website to get the slides, www.safetyleaders.org, you can click on the upcoming events in the upper right quadrant of the screen, and that will take you to the page where you can get the future content, video, slides of the presentation. Our purpose at TMIT is that we will measure our success by how we protect and enrich the lives of families, patients, and caregivers, and our mission is to save lives, save money, and create value in the communities that we serve. Our disclosure statement is on slide 9, and I won't go into it in detail, but we'll not be talking about any products, services, or technologies for which any of the speakers have any financial declarations or incentives. And our speakers and reactors are on slide 10, and because of time, we'll move fairly quickly through our agenda, especially in light of the big news regarding meaningful use, and have Ross Koppel be able to help us understand what's going on and where we're going. And a number of our wonderful speakers we've had in the past are live with us today, as well as a couple by audio. What we would like to do before we start is to have Jenny Dingman, who has been a tireless champion as a patient advocate for many years, founder of Pulse, and is a part of an ongoing support team that helps us really get the patient's message and point of view. Jenny, would you like to just start us off with a brief statement?
Thank you, Dr. Denham. I just want to welcome everyone here on behalf of patients and families. This is very exciting news, and this webinar is going to be wonderful today. Thank you all for being here, and I'll hand it back to you, Dr. Denham.
Thanks, Jenny. And we also have Dan Ford, who's one of our patient advocates, who will be speaking regarding the migration from one EHR system to another. So my job is to take the next few minutes and address a couple of things that popped up in the news and then meaningful use. And in December, we covered, so you could go back to our prior webinar if you like, the summary of the results of the HACs, the healthcare-acquired conditions results of focus on these events. And I think it's really great news. Many media elements and distribution systems covered the impact of the HACs, and you as a network, the 80,000 members that we have in our network that routinely log on to this webinar were participants in helping have that impact. So I want to remind you to go back to December. So what's in the news is that the AARP supported program in a couple of studies that were undertaken regarding home family caregivers has had enormous impact. And we recommend that you read this report that's up on slide number 15 regarding the home family caregivers. Now, what this has prompted is the CARE Act. And the CARE Act is the Caregiver Advise, Record, and Enable Act to better support family caregivers. And there are a number of states that now have adopted this into law, and this has passed the House of Representatives. Briefly, the name of a family caregiver is to be recorded in the electronic healthcare record or medical record. They're to be notified when their loved one is to be discharged to another facility or home, and most importantly, the facility must provide an explanation and live instruction of the medical tasks such as medication management, injections, wound care, transfers, and the activities that they would perform at home. On slide 17, we put together an up-to-date slide as to how many states have adopted this law, and the dates are in the table that you see on the right. I won't belabor it, but it looks like there are a number that are in the pipeline as well. Some of the press had covered them in California, where I live, and the impact that it can have. California has 37 million Americans, and I think it'll have an enormous impact, but it'll be slow and it'll take time. However, this is really starting to get people's attention and terrifically important for transitions in care. And as we talk about the electronic healthcare record and identifying patients and being able to have access to these, it fits beautifully with what we're talking about. The House of Representatives bill is called the Raise Family Caregivers Act. Again, take a look at this. Now, my second job was, so that was what's in the news from a standpoint of home family caregivers. I'm now going to move very quickly through our polling results on the top 10 health technology hazards for 2016 that were tied to the 2015. And just to remind you, in 2015, there was an overlap between ECRI's top 10 patient safety concerns and the top 10 health technology hazards. And data integrity, which is number 2 on your right, which is in fairly small print, was right there at the top of the list. For 2016, a new set have been put forth. And so if you look back in our webinars, you'll see that we've covered both of the top 10s for 2015, and we polled you regarding the 2016 list, and the list is on slide 23, which I'll go through. So for speed, I'll go through our polling information that we gleaned from you in December. The slide number 24 is a crosswalk you can refer to later. Again, I'm not going to read the slide, but you can see some of the areas have direct overlap between 2015 and 2016. However, none of the 2015, would we say, have gone away. So our polling results on the first one was cleaning of flexible endoscopes and disinfection. We asked how important that this was, and you gave it a 77. So 77% of you made it a 10, 94% across the board. Very strong results. On missed alarms, we asked you whether this is important to you. And again, this was to help us drive our health information technology community of practice. And on missed alarms, again, very high numbers. 69% of you gave that a 10. 98% of you said it was important, and only 3% had anything below a 6 on a scale of 1 to 10. This is telling us that you really, really feel like you need to have us address these in future webinars. Number 3 was opioid-induced respiratory depression. We know that last year CMS, HHS, the Innovation Center, had targeted 3 drug adverse events, and opioids were number 3 in the group, and we know incentives are going to get tied to these and absolutely critical. We ask you how important it was for hospital patients that receive these and that can lead to death. Again, an indication of what you believe is important and want more of in what we're sharing with you. So all of you are saying this is a major issue. 57% gave it a 10. On inadequate surveillance of monitored patients in telemetry settings, which was a new one on the list, still pretty high. 56% of you gave it a 10, a little bit lower than the others, and you can see the distribution with a fairly small number from 1 to 6. So 90% made that a priority. When we talked about operating room technologies and insufficient training of clinicians, again, high. So ECRI appears to be, the list appears to be a strong list. 52%, just a little bit less with a little bit more of a spread, still almost 90%. When we addressed errors arising with health information technology configurations and facility workflow, and I know Ross will speak a little bit later about this, or what the issues regarding the E.H.R., these not supporting each other, and we ask you how important that is. Again, ranked pretty darn high at 63%. You gave it a 10, and very small numbers under a 6 with a fairly, again, 97% of you said, you know, this is a major area and an area to focus on. Now, unsafe injection practices exposing patients to infectious agents, this scored lower. at 39% with kind of a spread in neutral to agree, and still 83% if you wanted to call a 7 through a 10 positive. But again, you're starting to see them drop off. The one that surprised us was the ECRI attention to gamma camera mechanical failures, which we had not seen in input from our network, and that was a pretty flat spread with about 61% in the positive, but you could see it's a pretty flat spread. And then failure to appropriately operate intensive care ventilators. A little bit higher at 36% for a 10, but spread out. And so that gives you kind of a feel for where that was. What this is telling us is that the topics of 2015 and the topics of 2016 are hot topics. I think a number of them haven't gone away, and some of the new ones are very strong. The one that also surprised us was this one regarding USB ports and using them in medical devices, and you gave it a little bit more of a flat positive focus. So now as I move, and I'm 8 minutes after the hour, and I think we've got some great speakers, I'm just going to go through some of the things that were in the news and lead into Ross Koppel's focus on the issues at hand regarding meaningful use and the errors related to the electronic healthcare record. For those of you, we have a significant number. This is a tough month for many people. We have a significant number that are going to watch this in a delay. We'll have a number of the papers up on the web for those of you that are listening to this and watching this with a delay after today's live webinar. But the announcement at the J.P. Morgan conference January 11th stating that the meaningful use program that has existed will be effectively over and replaced with something better really was a big surprise. And we'll have Ross describe a little bit more of the detail there. However, this was picked up by a number of the press outlets. It brought celebration and speculation to a lot of people that were longtime critics. Meaningful use in its current form has only added a layer of rigid functions to the clinician's workload, has not added any additional value for providing quality health care to patients. This is one of our CIOs of one of our leading organizations. The CMS had also addressed the fact that we'll have Ross describe what was announced after the initial announcement at the J.P. Morgan conference, but this is a quote from CMS regarding its focus now to focus on startup new consumer and provider-facing capabilities and then scale and nurture and mature them. So you know, where our takeaway is, and I think you can see by our attendance that has dropped this month, that with this amazing turmoil in this space, it's hard to want to step up to a community of practice when we don't know what our target is. One of the other topics covered with healthcare informatics was the CHIME focus of a global $1 million competition to incentivize early and new stage experienced innovators to accelerate creation and adoption of a solution for ensuring 100% accuracy in identifying patients, which is a daunting problem. So we're definitely in the zone where patient identification, interoperability, standards, this whole area, and now with meaningful use not having regulatory targets for us, without having substance to know where we go from here, it makes it tough. And that's why we're very grateful to have Ross with us today. Our prior speaker had to cancel on short notice, and we were very grateful for Ross helping us kind of sort out what's actually going on. Before he speaks, however, about meaningful use and medical errors, just to set this up, we also wanted to describe some of the things that have popped up in the literature regarding what we know about the medical errors associated with E.H.R. You know, there are a lot of things that are popping up on the blogs and in articles. This article in Journal of Patient Safety addressed some of them and showed significant delayed diagnosis for cancer, hemorrhage, tenfold overdoses are ignored. So we know that there's significant challenges. this article, just to draw your attention to it, available with the British Medical Journal Quality and Safety, and Gordy Schiff as the lead author regarding CPOE. We've mentioned this article before, and we've put it up in prior webinars. The slide number 52 addresses the top 25 and the top 25 why did it happen issues. This gives us some real focus on what's actually going on. So when we polled you regarding E.H.R. vendors and asked, should they be required to list products that they represent at least some risk, and this was regarding some of the topics that were put forth in a committee and was written in the press in Modern Healthcare about conflict of interest, our audience said almost 70% gave it a 10, that we really believe the E.H.R. vendors need to step up and tell us about risk. We asked whether you wanted a deeper dive on medical record contamination and cybercrime. You could see the score there at 72. 95% want a deeper dive. John Nance will be addressing this briefly before the top of the hour. And then we asked you how many of you would like to be involved in a community of practice addressing E.H.R. errors and harm. And this was an experiment to make the launch of this, or the first one, our regular webinar. So those that are not focused on the E.H.R. and health information technology likely would not attend. We know a lot of you are very focused on it. The data integrity and incorrect or missing data in E.H.R.s, you ranked extremely high, with 73% giving it a 10 on a net promoter score basis, with some and very, very strong support with not too many detractors. We ask you how many patients should have their own electronic personal health record. Again, you scored that fairly high. So we see that we really need to have that. Now, a lot is going on with ONC, and we'll ask Ross to help us understand a little bit more about this uncharted water ahead now that meaningful use is potentially meeting its demise. We, in prior webinars, talked about some of the articles in the New England Journal of Medicine, such as this one by Sitigan and Singh, and the frameworks that they were proposing, and we know Ross has some feelings about these. This is the 8-dimensional socio-technical model of safe and effective healthcare use that they propose to be used. The question is, how do we focus on these frameworks and move forward? And Ross has responded in DMJ to the proposed framework, and we'd like to have him help us understand that. So we pulled this article up and highlighted in red his comments regarding that. So as I introduce him, this is a book, a recent book that has come out. It's in its fourth edition, in which he has written the 6th chapter, and so he's, I think, giving us kind of a good perspective as to how we can interpret what's going on and provide perhaps a little bit of a voice of reason to some of the proposed frameworks and a check and balance to what we're hearing. We know now that with meaningful use effectively killed, and then some of the further comments have said, well, we're going to keep moving forward. It leaves us in a little bit of limbo. So Ross is a leading scholar of healthcare HIT and interactions of people, computer, and workplaces. He's had articles in JAMA, the Annals of Internal Medicine, New England Journal of Medicine, Health Affairs, Journal of Patient Safety, Journal of Clinical Care, and a number of others. He is on faculty of the Sociology Department and Medical School of the University of Pennsylvania. He's also a senior fellow at the Leonard Davis Institute at Penn's Wharton School. He has been a co-investigator on a number of studies, and I'm just going to move forward and ask him to help us interpret and understand what's going on now as we focus on a community of practice in this space. But I will say that now that meaningful use has an unclear future, there'll be remnants of it perhaps. We'll likely delay the community of practice until we have real clarity, but we'll ask him to give us some advice on that. Ross?
Hi. Good morning or afternoon, depending on where you are. So I have a couple of slides here. Let me skip And the first thing I want to talk about is what we know about errors, because a lot of the solutions or proposed solutions deal with reporting of errors. And while it would be psychotic to say, reporting of errors is a bad idea, I mean, failure to report is a good idea. I want to focus on the proportion of errors that we actually know. So this represents the universe of errors, prescribing errors, and this represents known errors, and this is the proportion that are reported because, after all, starting your career, you're a young physician, you're a young nurse. The last thing you want to do is destroy your career by reporting your errors. And more importantly, recognize that that is a tiny proportion of the universe of errors. And what do we study? We study that little dot. And that, of course, is just a fraction of the prescribing errors. Now, this chart represents, the next slide here, is both a patient in an airplane going along, not experiencing error. And then the next one is when they've suffered serious error. But if I go back a slide, you'll note that this guy looks exactly like this guy, but this plane doesn't look like the former one. And the whole idea of a National Transportation Safety Board coming in and investigating errors is inappropriate, in my opinion, because when there's a crashed plane or a locomotive or a truck, it looks like this. Whereas when we screw up with a patient, it looks the same. And patients tend to be old and sick by definition. They tend to have multiple comorbidities. They tend to be on 13 other drugs in a hospital. They have compromised livers and kidneys and hearts. Bad things happen to them when we do everything right. Good things happen when we screw up. And they have their own homeostatic system trying to keep them alive, which can or cannot work with us or against us. And so we often really don't know what's happening with patients when we screw up in medication prescribing errors. Now, obviously, if we leave a pair of hemostats in somebody's guts, that is an obvious error, and we'll find it tragically or otherwise. But with medication error, we usually have no idea. And if we do catch it, we stop it. Just belaboring the obvious here. So here are some questions that have been asked of me, but first I want to talk about some of the things that Dr. Denham mentioned earlier. In terms of patient ID errors, we are, of course, the only nation on earth that does not have a unique patient ID for our patients. And Bill Yanoff famously said 25 years ago that at any moment in LA, there are 3,000 Rosita Gonzalez's in hospitals in the LA basin at any point in time. And of course, some of them are sharing the same information and cards and are undocumented aliens, and others are using cousins who have insurance and stuff like that. The probability of a wrong patient error is dramatic. And so addressing the wrong patient problem and the wrong ID problem is a major concern, and I think we're just going to have to admit that, like every other nation on earth, we're going to need a unique ID. There are suggested solutions that are different, but we don't have time to go into that. The other thing I wanted to say before we spoke, before I get into my little answers, is the slide of Dr. Gordon Schiff and my study on studies of errors associated with the display in CPOE of Computerized Physician Order Entry Systems, Provider Order Entry. Actually, we did a very elaborate study for the FDA in which we examined 4 or 5 separate EHRs in 5 separate medical institutions. And we needed to get permission from the vendors to use actual screenshots so that we could show what happens when, for instance, a pop-up hides the current medication list while you're ordering, or you can't see the problem list, or drug names are truncated such that you don't know what dosage it is or something like that. So the vendors, after fighting with them, allowed us to use those screenshots, but they restricted us by saying only the FDA could see our report. So we have a very elaborate report with 53 pretty desperate, bad screens that lead to patient harm that frankly will never be seen by a human being concerned with patient safety or quality, except by 2 or 3 people at the FDA. And, you know, I'm engaged in a little guerrilla rage and trying to get that report released so that we can see. The version that you saw was a summary of reports, but it does not have the screenshots that would be so powerful. Okay, now let's look at some of these questions. The first one. Once when I was at a large conference, Farzad Mostashari said to me, so would you go back to paper? Would you give up EHRs? And I looked at the audience, which was several thousand, and I said, are you sorry you had kids? And of course there were a lot of titters and some outright laughter. We have invested so much into HIT. I'm coming out with a paper showing that we're spending about $3 trillion, that's with a T, on HIT for hospitals and doctors' offices and the like. And there's, you know, massive untold manpower and other treasure that's gone into that. Yes, we have moved the needle on the proportion of hospitals and providers who have healthcare IT, but we've also alienated virtually every clinician in the world who's using this software, which, while it has innumerable strengths and advantages, I'm not a Luddite and I would not go back to paper. It still has very primitive interfaces. It sometimes I argue that it's been designed to send doctors to their colleagues in carpal tunnel surgery because they have so many clicks and the like. So yes, we have dramatically increased the number of people who are using it, but we haven't. Now, on my version, I just lost my questions. Can you help me? Charles?
Kyle did it automatically. There we go.
Okay.
Got it back.
Got it. Okay. So, whereas it's been beneficial that we have an opportunity to use the systems and learn what we want and what we don't want, it's been a heck of a ride and a lot of frustration and disappointment. You know, to a large degree, we have the user interfaces circa 1997 or earlier. I mean, it's really a pity. So now we turn to the issue of reporting errors. Well, I've sort of addressed that. Obviously, we want all errors to be reported, and that's the essential. On the other hand, there are a lot of efforts out there that say that if we simply keep on reporting and reporting the errors, that we will make EHRs better, and that's not true, in my opinion. Now, again, I don't want to be taken as opposed to reporting errors. It's essential. But we know so few of them. What we really need is a system that allows you to report when you run into a clunky interface, when you when you're obliged to click 17 times to see two pieces of data that should be two pieces of data that should be contiguous are somehow separated by 5 screens or something like that. So all of these efforts at reporting are, in my opinion, a sort of feint, a sort of leave us alone and just report the problems, but it misses the reality of what is really important, which is the terrible interfaces. So, having answered my questions adequately or otherwise, let's turn to the issue of what's happening with MU, with meaningful use. So the original report said that they were killing it. And bizarrely, that was made at a J.P. Morgan conference on vendors and healthcare, which you can draw your own opinions about. Some people have made some rather Marxist comments about that. Basically, I think it's good. I think MU has been more of a frustration. I think it's obliged us to purchase software that has not been ready for prime time, that is that produces a lot of errors despite its myriad and wonderful advantages, and that it would have been better to first demand data standards, second demand interoperability, and third demand usability before we got everybody to spend a few $trillion on these systems. And by the way, when I say a few trillion, I'm not joking. So for instance, Harvard is spending $400 million to Epic, and then it's spending $1.3 billion on the implementation process, of which Deloitte is getting $700 million. My own hospital, University of Pennsylvania system, which is, 4 or 5 hospitals in many clinics, we already have Epic outpatient, but we're giving $400 million to Epic for its software and for part of the implementation, and then we're spending $1 billion on implementation. So we're spending a total of $1.4 billion, $0.3 billion less than Harvard. And other hospital systems have spent $1 billion. I believe Duke and UCN, University of North Carolina at Chapel Hill, spent about that on its implementation system. And of course that represents some money going to the vendor and then a large chunk of doing the implementation, the connecting or the various, literally hundreds of other systems to the E.H.R. and the like. So where are we with MU? Well, first they said it was dying, they were killing it, and then they said, but not so fast. It's now become a sort of potential vampire, the living dead of MU. They say it will be done and over by the end of 2016. Well, okay. But in the interim, they're still keeping, I believe, the incentives and the punishments, the carrots and the sticks. And they're still going to be insisting that we report stuff in their formats that most people find rigid and not productive. Very often we've been in a situation where we report that which is easy to report rather than that which is important. And that's often a problem in reporting systems, where we go for that which can be done quickly or easily, like, did you counsel the patient to quit smoking? Which is very different from saying, I've been working with them and they are quitting smoking, or they have reduced from 3 packs to 3 cigarettes a day, or something like that. So we go for that which we can click, and we all know the problems of that. I think I'm going to shut up, and Chuck, hand it over to you and ask questions or answer any questions.
So thank you very much, Ross. And I think, we so much of the work our safety and quality folks and chief quality officers have been focusing on are the basics, and then the meaningful use targets for these integrated healthcare systems with inpatient and outpatient have been basically a framework that gave them a rationale or a stick, if you will, to get everybody moving in this void, where, as you say, the phase of the living dead. I think it'll be important to know what advice that you might have to share. Ponder that, if you will, while we move quickly to John Nance, who can be on until the top of the hour. And I'd like to have John react to what you're saying before we go to Toff Peabody, because I'd like to have them kind of share some of their thoughts and reactions, and then come back to you with yours. And I know John has a commitment, so we'd like to have John present to us. And because this is a smaller audience that we typically, this is a focused audience on health information technology and our community of practice, there may be audience members that have not heard John talk about the classification and framework that he shared with us. And this will be part of our community of practice. So, Ross, much broader than just E.H.R, we're addressing the health information technology technologies that include but are not limited to what ECRI list was, and a big part of it are the HIT accidents and cybercrime breaches, etc. So perhaps, John, if you want to maybe react quickly, because I know you'll have to leave, to what Ross has said, and then take us through that classification briefly so the audience that's new to this group on the community of practice knows what you've covered and what we'll cover in the months ahead.
Okay, well, thank you, Chuck. First of all, I want to say that there's one thing we've got to keep very, very clearly in mind, and all this morass of difficulty with and without meaningful use, but all the difficulties that have arisen in part, only in part, by our failing to have a national standard before all these different companies got involved doing things themselves, whether it's Epic or whether it's Cerner or whatever. But one of the things that, when it gets to reporting, is absolutely vital is reconnecting us at all times with the ethic, basically, of what we're trying to do. My ideal, and many of you know one of the books I wrote had to do with this setting up of a paradigm of a hospital. But one of my ideals is we will know that we have achieved what we need to achieve when doctors and nurses and techs can skid in the door the next morning and say, ooh, let me tell you what I did last night. Let me tell you how I screwed up, because I don't want anybody else to have this happen to them. Now, that's the ethic. It doesn't necessarily mean the methodology. But until we are there, the rest of it is just filling squares, looking over our shoulders, and being concerned about the consequences of reporting as well as the structural aspects. That's point one. Point two is, what do you do with the reports? This is one of the big conundrums. Now, everybody knows I'm from aviation originally. Aviation hasn't hung the moon, and I very often tell audiences that we are one order, if not two orders of magnitude, less complex than healthcare. And Ross was kind of reflecting that in terms of showing the pictures of the crashed jetliner versus the patient that looks the same. But let me quote from Alan Mullally, who basically single-handedly saved the Ford Corporation over the last 8 years. Alan is a friend of mine who was running the commercial airplane division at Boeing before he went over to Ford. As he was being interviewed by a rather hostile crowd of automotive reporters just before taking the job with Ford, one of them said, what makes you think that you can handle the complexity of a car? And Alan laughed. He said, well, there are 30,000 parts on average in an automobile. There are 2.3 million parts in a jetliner, so I think I can figure it out. Here's my point. Whether we are talking about scaling up aviation or nuclear power generation to the complexity of healthcare, or whether we're talking about simply taking data in a flow that feels like drinking from a fire hose and making something useful out of it, not just because we want to please CMS or please some future form of meaningful use, but the major part is these are just numbers, guys and gals. These are just numbers. We can scale this up. In other words, the same principles that were involved in parsing out what went wrong will work for 10 trillion as well as they work for 30,000 in terms of the different points. So it is wrong to be, I think, intimidated over time by the complexity of this thing, because we have 320 million Americans, and all of us are dependent on figuring out a lot of these repetitious things that go wrong, and using the EHR and using what we have very imperfectly put together to figure out how to prevent it from happening again. And that is, and I know, Chuck, I'm ignoring what I was really going to talk about here, and I'll get to that in just a second, but that is one of the most important elements here that I want to talk about, which is we can talk about a medical version of the National Transportation Safety Board, but really it's meaningless unless we define our terms. As Voltaire said, define your terms and I'll speak with you. First of all, the NTSB looks at any incident or accident as a series of complexities. The ethos is to never look for just one cause, because there never is just one cause, exactly the same in medicine. So when they come in, they don't care about blame, of course. They want to lay everything out on the table and figure out everything that contributed to whatever it was that went wrong. Sometimes the airplane or the system that they are dealing with looks exactly the same at the end as it does at the beginning, and is just as much of a conundrum, especially with electronics. As a matter of fact, unraveling an accident like Air France 447 a number of years ago, which went down in the Atlantic, took every bit of expertise from all directions to figure out what went on with the automated systems. And we would still not know if they hadn't found the so-called black boxes, which, by the way, are, as many of you know, international orange. But the thing I'm trying to get to here is that the point of a medical version of the NTSB would in no way, form, or fashion reasonably take up everything that goes wrong, or even close to it. It would be a more representative thing, going in and looking at the things that we know we continually get wrong, whether it's things left in patients who shouldn't be there, wrong site surgery, misapplication of medication. You all know the list. It's long, but it's finite. You pick the things that keep happening over and over again, and you go in, and this is where this proposal for what we call a red cover report, because in aviation they're blue cover reports, is the apocryphal name given to the NTSB's production of the final report in each case. But a red cover report, by whatever name, would simply talk about the type of things that go wrong, using representative incidents to try to say, guys, let's get this right. Let's stop doing this. There is no reason to continue to make these mistakes over and over and over again. To that extent, to connect this back to the original topic, the EHR and everything that we're trying to do in IT must serve this purpose, not the purpose of filling squares, not the purpose of making CMS happy, but overall we've got to keep a steady hand on the tiller with CMS and everybody else, including what we laughingly call a Congress, on the basis of we have to keep pointing down the road and saying we cannot repeat the same accidents and injuries and mistakes. And one final point here before I go back over to the thing I've got the slides up for. One of the biggest problems that we have in patient safety and in all forms of medical practice in this country and basically throughout the world is simply this. When something goes wrong, we're surprised. We're surprised. How many times has everybody on this call said, well, I expected him to do that. I expected this to be that way. I expected that to be epinephrine in that cup. I expected. Well, we got to stop expecting everything to go right. The ethos of nuclear power generation success in changing their field, and same thing with aviation, and same thing in other industries, has been to say, let's find out everything that could possibly go wrong and anticipate it at every point in time. That's what we're not doing, and that's why the EHR becomes more valuable when you use it appropriately, whether we're dealing with trigger tools and trying to figure out what happened over time in a realistic way, or whether we're dealing with trying to construct a new flow of evidence that's going to be useful on a literally an hour-by-hour basis. As a matter of fact, that's one of the things that I know some of the folks out there working on this have not only envisioned but are testing an algorithm to extract real-time information from an EHR and sound real alarms to hopefully a command post type of situation to let you know that a patient right here, right now is in danger based on a background of a particular algorithmic projection of what has happened in the past, not only for them, but for the entire population. You know, we are complex as human beings, there's no question, but it's just a scale up in numbers from the complexity of a 3.2 or 2.3 million part aircraft. Now, when I was on before on the seminar, or webinar rather, that Chuck graciously brought me into, on cybercrime issues and HIT difficulties. One of the things that I have been and am very interested in, very curious about, is the the way that the march of misuse of cybernetics in all forms, but especially information, has impacted not only the field of medicine, but literally in all directions, impacted life. Recently, I spoke to an international, two different speeches, an international organization of credit card companies about this very subject of cybercrime and how they are battling this literally on a daily, hour-by-hour basis. And it was interesting that the same problems that they have are the same problems, in effect, that we have in medicine. It's down at the point of contact. Yes, we've got criminals out there trying to break in, trying to do certain things, and I'll outline that in just a second. But basically, their response has been one of trying to take the theoretical down to the actual practical application. This is where it's extremely important to have everybody on the same page on philosophy, strategy, as well as just the tactics. So even the credit card companies are fighting the same battle of how do we get our information, our reports, how do we get our individual consumer contacting members, in other words, the merchant out there in the field who's got one single credit card reader, how do we get them all on the same page? How do we get them motivated to do the right thing? And how do we present a common front against the enemy? And there is a big enemy out there. Identity cybercrime is just the beginning. Computer crime, identity breach, theft, counterfeiting. These are three categorizations that actually over time can be expanded to medical identity cybercrime, which I think a lot of us are really kind of unaware of. I was unaware of it just a year ago. Basically, what's going on there, breach is when somebody gets into the data, theft is when they take it out, counterfeit is when they start manipulating it, and then the damage, contamination, or vandalism can be even worse on an order of magnitude than what we have when somebody steals our credit card numbers, because those are going to be shut down fairly rapidly. When you end up with medical ID damage, you can end up, as some people have, denied access to your own medical record because there's a gross misinterpretation of the law to say that HIPAA, if somebody else's record now has been contaminated with somebody else's information, you can't see it, and that's absurd. That's not anything in the law. But that is what has happened to a number of people. Sometimes it takes almost $20,000, $30,000 on average for this burgeoning crime when somebody gets in and uses a medical identity to obtain goods, services, and basically obtain medical care that they are not entitled to. There's very little protection. Certainly we're into a new area of crime, and many of you know I'm a lawyer, and it really chaps me to say that over all these years of technological development, it's been the same thing. The law is always 20 or 30, sometimes even 40 years behind what's happening in real society. Healthcare professional identity is yet another dimension of this, and it is getting to be a major problem. Not only the theft, counterfeiting, as you can see on this recitation, publication of fraud, and misconduct, that is really worrying me. Why? Well, for one reason, we don't have any reliable mill, if you will, that we can all trust and rely on to churn out what is the best practice as currently known, not only in what's being done around the world, but in what all the papers say that we know we can trust, because there are too many out there. Yes, we can trust the Journal of the American Medical Association and the New England Journal of Medicine, but there are journals out there that consistently are identified as really being not only not trustworthy, but it can go further than that. We have a lot of ID contamination going on. We have people who are actually purposefully interdicting somebody's information to the point of trying to wreck their career, and we are just at the very beginnings of even understanding the impacts. I'll go through these very quickly. This is what I was just talking about, the overall identity cybercrime or computer crime. Again, breach is just getting into the system. Theft is taking something out of it, out of your database or somebody's database. Counterfeiting is beginning to manipulate that, and then we go into all forms of harm, contamination, harm, vandalism, etc. Medical identity cybercrime, again, you get down into ID breach and theft. Medical record blocking, these are increasingly serious. I mean, literally increasingly on an almost daily basis. This is a Wall Street Journal article that I would cite you to of August 7th of 2015, very current, talking about this and pinpointing. And by the way, again, this is Wall Street Journal, August 7th, 2015, if you want to take a closer look at it. It makes these points very eloquently. Professional identity cybercrime, we've got to get a handle on this. We cannot, in the absence of having a particular organization, whether public, private, or whatever, that we can trust in medicine to tell us what the best current practices are as known, or I should say the best practices as currently known, and the standard of practice, the standard of care, then we are looking to journals, and those journals have got to be trustworthy. If they're not, if they're putting out things that are based on economics, in other words, how much money can I make if this particular drug gets patted on the back, then we are in deep trouble. And folks, we're in deep trouble because I don't think this has been sufficiently recognized. Here's another article, National Academy of Sciences. This conduct accounts for the majority of retracted scientific publications. Now, pay attention to that, please, if you're all interested in this, because the numbers in here will stagger you. The numbers in here tell us that we've got a house on fire. It's not just a burning platform. More than 2,000 retractions studied. 67.4% retractions are misconduct, including fraud, and fraud itself is up 10 times since 1975. That is a call to action. And before I relinquish the so-called microphone here, back to the red cover report, we're still trying to figure out a way to do this. But it is absolutely, in my view, necessary. There are so many things to be learned that we already know. If we could simply find a methodology of tapping everybody on the shoulder and saying, look, read this summary of the type of problem that's been occurring all over the country in hospitals and in imaging centers and everything else. Read this and you'll understand what not to do. If you, and I've said this to many of you, but if you basically lean into a pilot's lounge, professional pilots just about anywhere in the world, and toss a new blue cover report on an accident we all heard about or one we didn't hear about, better be prepared to jump back, because as pilots, we will all dive on that report. And the reason why is we want to know what's happened to somebody else in some other systemic way so we can make it not happen to us. That's the beauty of something like this. A red cover report does not go into every single medical accident, misadventure, and situation that's occurred. What it does do is bring together the current knowledge that usually remains hidden behind reporting systems that are not only inadequate but are not used properly, that have the wrong ethos. In other words, we're only going to report what we absolutely have to. And quite frankly, and I know many of you will disagree on this, behind things like M&Ms that basically provide an opportunity to say, okay, don't go forth and sin no more, my son, but it isn't going to get the information out there. We've got to put all of this out in a way that says we are unafraid to talk about our own mistakes in a particular hospital, a particular system, a particular doctor, a particular nurse. We're unafraid because we know our ethical obligation and our passion is to make sure that these mistakes never happen again. That's what this concept is about. Chuck, thanks very much. Sorry to ramble on.
John, many thanks, and we appreciate both you and Ross going through quickly, knowing that you have a critical commitment, and most of you know that John is the ABC commentator on safety and airline safety, and has been just a fabulous contributor to healthcare and the crossover. So, thank you. So, John, if you do have to go, thank you very much, and we really appreciate your comments. And for those of you that log on after the fact, a lot of the assets we've discussed will be posted on the page where you download the slides and where you're watching it now if you're watching a delayed on-demand version. So it's a great pleasure now to have Christopher Peabody. Many of us know him as Toff. Is an MD, has an MPH. We met about 7 or 8 years ago at Harvard when he was a Zuckerman Fellow, a very prestigious post that he was appointed to while he was in medical school, and took a year there at Harvard. Went through his emergency medicine residency program, was so committed to patient safety after we had a chat that he has had tireless contributions to NQF safe practices interpreted by medical students, a number of training areas. He's a frequent speaker at major patient safety events, and now he is a assistant professor at UCSF in San Francisco and a practicing emergency medicine physician. He also has had a international experience, having worked in Haiti during the disaster. He's been in China. We've invited him to participate in collaborative efforts with the WHO, and he now has an enormous interest and competency in health information technology, and that goes far beyond just emergency medicine, and has been a content leadership contributor to Care University, which is where we are addressing both caregivers and patient and home family caregivers. So, Toph, we'd like to have you walk us through some of the frontline problems and solutions. And before John goes, if you have any comments on what John says, and then Ross, we'll come back to you, and Jenny, and Dan Ford, who will be our anchor man, talking about how to get patient advocates and how they're being used in EHR adoption. So, Toph, take it away on health IT, frontline problems and solutions. He will be our leader of the community of practice, which we will delay until we see where meaningful use is going. But in the interim, please address these issues at frontline and the problems and solutions, Toph.
Chuck, thanks so much for that very generous introduction, and it's just an honor to be on with gentlemen like Ross and Dan, who you're going to hear from in a little bit. And of course, it's always fun to hear from our experts in aviation, and can't thank you enough for participating in the webinar today. And especially in this time of this, where meaningful use is potentially throwing us for a loop, and what we're actually supposed to be focusing on as far as implementing these health information technology systems, not only into our emergency departments, but into our hospitals and institutions in general. I'm going to focus a little bit on the emergency department today, and kind of walk us through a case, because I learn by cases. I'm a clinical guy. I work at San Francisco General in the emergency department there, about 3 shifts a week, and I learn by learning through cases, and so I would kind of want to walk through a case that I know can happen at any emergency department around the country, and then give us some resources on how we can actually potentially avoid some of these errors that we see, not only in emergency departments, but in our institutions in general. I think of the emergency department as a microcosm for healthcare, and it's basically where we initiate our most critical care in the hospital. It's responsible for over 2/3 of hospital admissions. We have rapid turnover, constant interruptions, and the emergency department contains unfamiliar teams and unfamiliar patients, meaning we don't have scheduled care. There's not appointments. People come in when they have an emergency and expect to be treated in a highly reliable manner. So how do we create a highly reliable environment in an emergency department where people are potentially never will see each other, that are working together as a team in the most critical situations in the hospital? And so I think that's our main question. How do innovations in health information technology ensure, how do they actually work for us in the emergency department and in our institutions in general? And so I'd like to just start with a case, if that's okay. And this is a case that many of us may be familiar with, and it's becoming one of the test cases for the potential errors that can happen with in the field of health information technology, especially related to E.H.R design. And it's a case that could happen anywhere in the country. And so on September 25th, 2014, in Dallas, Texas, this patient, Mr. Duncan, arrived in the emergency department with dizziness, abdominal pain, headache, and fever. Very common complaints for an emergency physician. Now, Mr. Duncan went in and received a separate nursing and physician assessments. And while his recent travel from Liberia is noted in the electronic health record, that information was obtained by the nurse who had actually seen him. The physician never knew about this information, and that's because on his electronic health record, he didn't have access. It was a drop-down menu to look at the travel history. So he had never potentially accessed this critical information that could have potentially saved what became patient number 1 of the Ebola crisis that happened in Dallas in 2014. So he had received a large workup in the emergency department, was discharged home with basically the diagnosis of a viral illness. that had that physician known about that critical information in the electronic health record that was actually in the electronic health record, the system actually knew that he had traveled to Liberia, but had that physician known about this recent travel, I'm sure this could have been stopped where it was. So electronic health records are actually, errors that are created by electronic health records actually had a really strong point of this Ebola outbreak that we saw in Dallas. Excuse me, the one patient we saw in Dallas with Ebola. So takeaways from this ED visit. There was inadequate communication and an over-reliance on the EHR to convey critical information. This is point number one. Second thing is that the travel history was not included on the standard assessment screen of an EHR. So there's no decision support that actually brought this to the clinician's attention. And this goes back to what Ross Koppel was telling us before, in that changes in design could actually improve electronic health records and help us help the technology help us provide better care on the front lines. So it appears that technology may have displaced good team practice here in this case. Poorly designed health IT was partially responsible for this national event. And we must ask, does health IT provide the right information at the right time to make the right decisions? And if health information technology could actually do these things, it would actually work for us and help us provide better patient care than what we did before. Now let's think about this in kind of a broader context, and this is something that we'll dive very deep in once we start our community of practice, but that patient harm related to health IT is rarely a hardware problem. If you look at this chart here, this actually goes over some of the, again, reported Sentinel events, and I'm sure Ross will have some comments on this, but some of the reported events that the Joint Commission researchers analyzed, and it looked at patient harm related to health IT, and as you can see, the two biggest things here are actually how the human, the provider in this case, interfaced with the computer, and workflow and communication solutions are actually where the most patient harm related to health IT happens. And so what are some resources that we can address this? And this is really where the community of practice will kind of focus down on. Health IT-related patient harm stems from the human-computer interface and workflow and communication. What do I mean by that? So in this case, human-computer interface was basically this poor data display. The output of the patient record was is virtually unreadable in many of these systems, and critical information such as travel to Liberia was not easily accessed. Second, workflow and communication. Now, communication failure. This is ironic given that we were actually sold on electronic health records and health information technology systems based off of this, that communication would be improved, mostly because there wouldn't be handwritten notes anymore, and you'd actually be able to read what the physician or the nurse was trying to communicate in the clinical context. But however, what we see now in emergency departments across the country right now, as we speak, is that the patient comes into the emergency department. They're usually evaluated by the nurse first. The nurse then goes and retreats into her area of the hospital to chart, and then basically relies on an electronic health record to convey that information to the physician and other members of the healthcare team. The physician then goes then and sees the patient and retreats to their area. So they never actually have face-to-face communication about the care of the patient that they're both caring for. And so that is an issue here related to health information technology. How does health information technology actually improve workflow and communication? How can we improve on that? Here are some actual resources that you can use to answer some of these questions that we brought up today. One of these is an older resource here, but the Joint Commission Sentinel event on safe use in health information technology really drives down and really drills down into some of these, some of the more technical aspects of how HIT, especially EHRs, are causing patient harm. Here's another one here from as far back as 2008. But one of the really amazing resources, and this is going to be interesting to see how this changes now that meaningful use is changing, is actually at this this website here, healthit.gov. if you go to this website and you drill down into the safer guides, there's a nice little video here that you can play that kind of demonstrates what the safer guides are. But these are actually for busy clinicians or busy, my medical director will use these when we have an event related to EHRs, and how we can actually improve some of these errors, workflow communication aspects, the socio-technical dimensions that we had mentioned before. They basically have these really cool checklists that clinicians can use. And so I've pulled the one here for clinician communication. And so you can go through and do a self-assessment with their checklists, and it kind of gives you prompts, and you can kind of look at how your EHR interacts with your workflow in your institution. And then it will give you resources to help you improve that. And so I think this really helps us close some of the gaps that we have here in addressing these patient safety errors that we've seen here with health information technology. I'd like to end there, Chuck. I mean, the community of practice is going to really drive down in these in a lot more detail. But my last point is the point we always come back to, in that health information technology cannot displace team practice. Those two monitors there in a really busy emergency department cannot replace you cannot interface just with that computer and expect your care to be highly reliable, expect it to be delivered with the compassion that we all have as healthcare providers. This is not the reason why we went into medicine. It was to be in front of patients, to be providing care on those front lines, and instead we're now spending most of our time in front of that screen there. And so how can this technology actually help us provide a more efficient, safer, and better care for our patients? That's something we hope to address in the community of practice and hope to address throughout our careers. And Chuck, thank you so much for the opportunity to speak today, and I look forward to taking comments from the audience and hearing now from Dan and how we can keep drilling down into having patients participate as we go through these kinds of exercises to help us improve our health information technology. Thank you very much.
Thank you, Toph. Really appreciate it. Appreciate your passion in bringing a lot of this practical sort of focus into place. And before we start with Dan, we have just two polling questions. We polled you an awful lot in the last year, but we only have two. One is, do you agree with a delay in the health information technology community of practice while we're waiting for meaningful use and its replacement to be sorted out? Or do you want us to move forward with some of the areas like alarms and a number of the other areas? Our bias is probably to make it more valuable to wait and then launch it. But put in the second, so you can score whether you agree with a delay. We're proposing a delay. And the second question is, given the polling results, the demise, what would the topics be that you would like us to prioritize as we move forward? And if you passionately believe we should continue with the community of practice, the topics state that you want to continue, you think we should get going now in the interim on some of the topics we know are really important and are not EHR perhaps related. And if you could just answer those questions, only two today, and we'll move to Dan Ford. Now, the reason that Dan is a speaker, and typically he is either a speaker or a reactor, but one of the most critical areas now that needs to be addressed, and Ross and I had a conversation with some of the other speakers before before we started, is this migration from one EHR platform to another. Many are moving from one vendor to another, and this requires an enormous amount of work. And when we wrote the NQF Safe Practices for CPOE, we realized that really the care re-engineering and the work process flows all have to be done properly, and then CPOE and the EHR are then laid on top of really good pathways. And to just put an EHR, throw it into place is like paving the cow paths, just trying to make it do what we usually did, and in many cases increase the speed with which we make the same errors and harm. And Ross can speak volumes about a lot of things that could really help us. But what we'd like to have Dan do is really address, because he's been in a recent Visioning exercise with this E.H.R. vendor transition, and he was a patient advocate and invited to be involved in the process. And we think it's a great challenge to all of us as we move from one system to another to invite patients to be involved and represented and have a voice. As many of you know, Dan has developed a deep passion for patient safety, having had major medical error in his own family. He is has been in the healthcare industry. He's retired now, but he was very active in placing, as a profession, placing CEOs and board members and top executives at healthcare systems, giving him a rare view of two ends of the continuum. One, the front line with the work that he's done with all of us and many of us in patient safety, and then knowing what's going on in the boardroom and helping organizations pick the best people. So Dan has been a published author with us in patient safety journals. He was a contributor to the NQF Safe Practices as a representative, and is an ongoing, committed patient advocate in many, many ways. So Dan, would you take us through your experience, please, of being in a recent visioning exercise when a major health system is making the move from one E.H.R. platform to another? And then when we're done, we'll open things up to Ross, who started the ball with us, and reactions and things that he'd like to add to what he's heard from the other three speakers. Dan, go ahead, please.
Thank you, Chuck. The project I'm involved with, as you can see, is called the Nexus Initiative, Spectrum Health, Grand Rapids, Michigan, West Michigan. A couple things I am not. First of all, I'm not an employee of Spectrum Health. This is not a promotion for Spectrum Health, even though with my involvement there, very close involvement, I can easily feel very, very good about this system. I'm not representing Spectrum Health as such, although I've got a number of slides that were provided for approval for me to use in this webinar, and I appreciate that. And then I've got a few slides at the end that reflect my own thinking as a PFAC member. I was the voice of the patient in this first event, an inpatient visioning event. There will be a number of other patient advocates, patient advocates or the voice of the patient, PFAC members involved later. The slides are going to cover this. The backdrop is on Spectrum Health, is on the PFAC program of Spectrum Health, the process improvement program on Spectrum Health, the linkage of the PFAC and the process improvement that will move this project along for Spectrum Health, and then the important role of the PFAC members. Here's a slide that depicts the locations. They have 13 hospitals, and we've got 170 ambulatory and service sites. I'm going to flip to the next slide real quick, and then I'm going to go back. You can whoops. Maybe the slide disappeared. There's another slide that shows the proximity for those that don't know where Michigan is, and found every now and then some people don't. It's West Grand Rapids is on the west side, and if you look about 45 miles over as the crow flies from the shoreline here, you come to Chicago and Milwaukee. We have Spectrum Health has 170 ambulatory and service sites, a number of comprehensive post-care services, a medical group of close to 1,100 employed doctors and advanced practice providers, a very large health plan called Priority Health, 575,000 members, and it is West Michigan's largest employer with 22,000 employees. The PFAC organization, the history started back in 2005. It's a very rich, very active, very, very well-regarded patient and family advisory council program. I happen to be a member of the one in the center there, the Executive Council, which is more of a coordinating body than a controlling body of the others. The others represent the major hospitals in Grand Rapids, large hospitals, and I think I neglected to remember there are around 1,500 licensed beds throughout totally in the system. So you've got some large hospitals in Grand Rapids. You've got another number of other regional hospitals. Excuse me. And then you've got service lines that the PFACs are named after and function accordingly. And we've got 150 plus members totally in this PFAC program. Performance improvement, I'm not going to say a lot except to reference the fact that it uses the Toyota production system, which is typically referred to as lean. It uses very successfly in industry and manufacturing, and has been moved over now into healthcare. We got some people like John Toussaint, Gary Kaplan on the West Coast, and others that are playing a very much of a lead role in terms of a very deep application into the culture and into the operations of a typical hospital. And we could use much, much more of that. Okay, so we got Spectrum, we got the PFAC program. This is more on the process improvement. Two pillars are respect for people and continuous improvement. And I'll let you look at the rest of them later when you look at these slides on your own. Okay, the thrust of this initiative is to move from EPIC and Cerner, and as Ross Koppel noted, hundreds of other smaller systems into EPIC. EPIC is going to be the surviving IT system. And it's just not a matter of flipping a switch, as everybody knows. The thrust of it is to have one patient story. And every time somebody inputs from someplace, it will go into this into the one patient story electronic health record, and and hopefully the patients will have immediate access and can input. Bills can be accessed, and just a lot of transparency. Okay, let me see here. I'm going to skip this in the order of time. I've got some more thoughts on the initiative, but I'm going to move beyond that. Okay, the initiative includes transitioning to a single electronic health record, as I noted, and billing platform to enhance the management and stewardship of all patient information. Keyword, stewardship, came up in what Toff just talked about in Dallas. Improved communication across care settings, create a safe remote.
Dan, can I interrupt you real quick? Ross, it looks like he's going to have to leave quickly on, and I wanted to get, before you describe your experience on the EHR, Ross, would you like to just comment on what you've heard, because I know you may have to leave just before we wrap up, and then Dan could then describe a little more on the experience. Would you like to do that?
Thank you very much. Unfortunately, I have another commitment coming up. First of all, I love all of the presentations, and of course, what you don't know is that I had a copy of Thomas Eric Duncan's EHR screen within a day of his death in Dallas. And even though I knew his three temperatures, starting at 103 and going down to 101 as they continued to hydrate him, and as he was bleeding into his gut, it took me 20 minutes looking at the EHR to find those three temperatures, which were the telltale indication of his problem. The EHRs are not user-friendly. Sometimes we call them user-hostile. And we need to fight for a better interface so that we can do the things that we need. We need to recognize that they are stunningly complex devices, and that when you change one line of code to respond to one sort of screw-up, there's an almost 100% certainty that something else is going to screw up somewhere along the line, and that it's only by careful, constant vigilance that we're going to be able to find those mistakes, and that there is no easy solution. We need to constantly be examining what they're doing and how we're doing with them, so that we don't get complacent for a second. Because remember that there is no such thing in a weird way as an EHR. There is a constantly shifting set of codes that are being adjusted as the surgery department says we need this, or the nursing department says we need that, or Pfizer issues a new drug or a new version of a drug, or the patient load shifts, or different kinds of doctors come on. The idea that the technology is a thing that we can set and say, oh goody, we're done, is ridiculous. It's an ever-evolving situation. Plus, the average hospital has literally between 200 and 300 or 400 other IT systems, all of which have to connect with the EHR. And sometimes it's more than that because they connect with each other and then to the EHR. And so it's a thing of extraordinary complexity. And it's only our ability to be aware that it's not responding to our needs that keep us alive and make our work possible. But we can never be complacent. I'll answer any questions if you have any for a minute or three.
Yeah, and thank you, Dan, for being so gracious to allow Ross to jump in. Toph, if you've got any questions or comments that you'd like to share with Ross before he leaves.
Ross, can you hear me now?
Yeah.
So I was hoping you could actually talk a little bit more about some of the design elements that you saw, and especially how you think these design the interfaces with the provider and the computer actually how does that affect workflow? That's a large question, but I was let's relate it back to the case that we presented. It seems like you have intimate knowledge about that. How does that design interface actually impede or improve workflow?
Well, okay, so the other day I was doing grand rounds at some unnamed hospital, and we did a talk aloud, think aloud with a cardiac fellow. And I watched her using the E.H.R. to find hypertension, which you'd think a cardiac fellow is not unfamiliar with. It took her 12 minutes to find hypertensive disease in the E.H.R. because she had to slide down a slider on the drop-down list and slide over on the slider across the screen horizontally. And then, of course, it was under E for essential hypertension. That kind of thing is just maddening to a busy doctor like you, Tom, where things that should be obvious are not arrayed. We find examples where tests, lab reports are listed by the name of the lab, by the name of the doctor who requested them, by the name of the technician, by the order in which they were put in, by the order in which they were put out, by the unit that dealt with them, and all of that. These constant surprises and this sort of chaos of presentation of data make your incredibly difficult job even more difficult. We should not be fighting these darn pieces of technology that cost so much and require so much effort to install. They should be our friends. And how come we can order something easily on Google and somehow on Amazon and it comes up? We can search for something on Google and it comes up. But using the E.H.R. is an exercise in frustration and patience. It just makes no sense. We know a lot about human factors, but the industry has fought human factors and usability testing until the last couple of years where they've said it's very important. But there was a report the other day, just the other day, in JAMIA, in which only about 5% of the vendors could justify what they had done in terms of usability testing and improvement. In other words, they were required by the ONC or CMS to list what they were doing about usability, and almost none of them filed any reports. They treat it like an unwanted skunk at the picnic. It's outrageous that something that is so needed for clinical care is dumped upon by the vendors as not important. I'm going to shut up now.
One more quick question. We have F. Francing asked the question, what do you think about doing failure mode effects analysis, FMEA, to systematically study potential errors in the EHR in defined patient care areas?
Oh, it's essential. I've used it. I've benefited from it in my writing because I've sat in on them. I've had my students and colleagues sit in on them, and they're an important and essential element of any work.
Well, great. Ross.
That question's so easy. It's a piece of cake.
Well, good. Well, thank you for asking it.
Thank you. And I'm sorry for interrupting.
No, that's okay. We'll go back to Dan to let you finish.
Okay. Thank you.
And then we'll thank you, Ross. We really appreciate you for stepping in. Dan, so sorry, and thanks for being so gracious.
Sure, that's okay. For those that might have looked at the screen, I did happen to slip a few slides past there. And the one just before this really talks about how the whole PFAC structure, the patient and the PFAC structure is going to be aligned for participation in this project. This was our visioning event 2 weeks ago. We had at least 50 people register, and more than that were in and out of the meeting at various times. It helps set the stage for the future. There will be visioning events for the ER, for ambulatory care, and for a handful of other of the service lines. And if you look at the right, you can see the windows, and on the left, we utilize those windows in the process improvement piece of this event. There were themes here: the patient experience, the team-based experience, staff experience, transparency, discharge, and transitions that were tentatively identified at the meeting as work groups for the future for this particular area. Real quickly, the voice of the patient. I think I have maybe 2 slides left. The patient stories are important. Help start it each day with a patient story. It helps us to read the patient there, reminds the group of the patient-centered care and patient engagement. Needs to have the voice of the customer at the patient. Spectrum Health is so strong about this and having an equal voice. We're encouraged and invited to speak up. We're listened to, our ideas are incorporated, we're appreciated, and we're thanked. And as process of care teams evolve in terms of this implementation, PFAC members will be involved in those as well. One of the things I've noticed, I've participated in 7 process improvement events over the last 17 months. Power gradients are minimal and almost non-existent, not only for and with patients, but with physician, nurse, pharmacy, other caregivers, and staff. All participants are encouraged to speak up. There's no condescending remarks. There are pushbacks that are respectful, and while we're working at being genuine listeners. We're PFAC members, the voice of the patient, we're mindful of and represent the patient's interests, the needs, concerns. Providers are this to a degree because, after all, providers are patients and family members at some point, but other responsibilities that providers have really dilute their focus. We're volunteers, we're not employees, we're free to speak our minds without worry about being politically correct or being fired. At the end of the event, I was asked, as the voice of the patient, to give my summary on my perceptions of the preceding 3 days. Hospitals and systems, this is a pitch for PFACs. Every system and hospital in the country should have 1 or more PFACs and invite patients and family from the community. Many of us have really good and or bad, there's not such thing as a good-bad experience, but good and or bad experiences who can contribute in constructive ways. And it's a way of giving back as well. It requires time, it requires a commitment, and a willingness to be honest and straightforward. I think I might have told a little bit of a lie. I think I got one more. I see patients and families as leaders and role models for speaking up and support while being good listeners, supporting the willingness of others to share their ideas. And we don't have to agree with each other around the room. It's not always comfortable. Those of us who've experienced tragic medical errors have found much discomfort. It's what we do about it, and that is not only PFAC members, the voice of the patient, but everybody in the room. It's what we do about it that makes the difference. There will be a lot of uncomfortable pieces as we go along, and I look forward to the journey. Next two slides are just backdrop information on my involvement, my participation as I evolved overlap over the last handful of years from a very active healthcare executive search consultant to become a patient and patient safety advocate. Here is contact information unless anybody wants to make contact with me. If you have questions about this project, I can get you to the right person. And I thank you very much. Great faculty today, and I'm honored to be part of it.
Thank you, Dan. Terrific. So, I think that this has been really, really helpful, and, we were really thrown a curveball on our community of practice with meaningful use apparently having the plug pulled. However, it's just kind of an unknown future, how the incentives and the penalties might still be a remnant. And I think it was, although it was a funny statement from Ross, this vampire, the walking of the living dead, could be something that's going on. So we're going to focus on trying to find out what this means and how it could tie to the community of practice. Toph, do you have any conclusionary remarks you want to make before we go to Jenny? And Jenny, I know we've not tapped you, but we'd like to have you just reflect on what you're hearing and maybe also put the vote in for patients and families being involved in the process. So, Toph?
Hey, thanks, Chuck. I, again, really appreciate being on as well, and I think that as we really dive down into what we need to accomplish, it's going to be exactly what Ross said, in that we need to enable our caregivers on the front lines to actually provide efficient, safe, quality care to our patients using tools that actually work with them, not against them. And I think we're onto something here. And I think if people want some concrete information on how to start looking into their own health IT systems, those safer checklists have really helped us look at our workflows and made some improvements. And I think it would be beneficial for the community of practice to dive deeper into those. And in the meantime, people can do those on their own as well. That's my main takeaway today, Chuck, and I, again, really appreciate the opportunity.
Great. So, Jenny, we want to finish on time, and we have a smaller group today because it's 100% focused on the health information technology and its experiment to see if it was of value. So we hope we get good feedback on that. Jenny, would you like to comment on what you heard and close us, and then you will be closing the program for us today. Thanks, Jenny, for doing such a great job and always being there for us to support us.
Thank you, Dr. Denham. Well, I'm pretty shocked to hear this news. As a consumer, patient, family member, it's very complicated for folks like myself anyway. And I just hope that the healthcare takes advantage of the factors that we need to make things simple again and keep it a little bit less complicated, because the more complicated things get, the harder it is to really put forth the best work, and there's always room for errors when there is too many complicated issues involved. So I'm hoping that maybe something will kind of simple it down a little bit in the future. And I also strongly support what Dan Ford said with regard to PFACs, patients and families participating. And many of us are so intimidated by all of the a lot of the complexities that we are seeing with the IT and the systems. It's very hard to understand. So I think this is probably a really good thing, and I'm really excited about the future and what they're going to replace it with. But if there's a message from myself and many of my colleagues in the consumer arena, we just want to keep it simple and keep it safe. I thank everyone for being here today, and it's been an honor to serve on the call. And God bless everyone here, and thank you very, very much for being here.
Thanks, Ginny, and thank you all for attending, and thanks for the questions that came from our audience. And this closes today's webinar. Bye-bye.